Hello students. So first of all, I like to thank and appreciate a wonderful initiative by the Medusane team, especially for the usefulness of the students during this lockdown period. And I am Dr. Aravinth, working as Assistant Professor in the Department of Pharmacology, Tagore Medical College and Hospital, Chennai. So today I'm going to discuss about one of the most important topic in the pharmacology for the theoretical purpose as well as for the practical purpose, that is the pharmacotherapy of bronchial asthma. So this is the overview of my today's presentation. So first we'll start with the history of the bronchial asthma. So how the disease initiated in the ancient history and in which stage is it now, and second about the public health, that is the statistical importance of the bronchial asthma in the current estimated population, and the risk factors, pathogenesis, diagnosis, and the current drugs used in the treatment of bronchial asthma. And in addition, I will also cover about the recent advances used in the treatment of the bronchial asthma. So what is this bronchial asthma? Bronchial asthma is a chronic inflammatory disease of the airways in which an inflammatory agent causing reversible and the periodic airway constriction leading to symptoms such as wheeze, cough, breathlessness, and the chest tightness, etc. So to make and to understand very easily, I will say you 3 points to remember in any respiratory diseases. First one, whether it is an acute disease or a chronic disease. So bronchial asthma is a chronic inflammatory disease. First point. Second, whether it is a reversible or irreversible. So bronchial asthma is a reversible airway disease associated with what type of cardinal symptoms? So the cardinal symptoms in bronchial asthma is the wheeze, especially expiratory wheeze, associated with cough, breathlessness, and the chest tightness, and also associated with the fever in case of severe infection. So it is a chronic inflammatory disease. It is a reversible disease associated with this cardinal symptom. So this is the 3 easy way to remember any respiratory disorders, okay, especially to say the medical definition. So it can present at any age group, and majority of the cases are diagnosed in the childhood itself, and most of them become asymptomatic at the adolescent age group, and the disease severity rarely progresses, and patients with severe asthma have it at the onset itself. So history, bronchial asthma was recognized in ancient Egypt and was treated by drinking an incense mixture known as Kai-Fi, and this Kai-Fi is used now for especially mixing with the perfumes for the smell. And bronchial asthma was officially named as a specific respiratory disorder by the father of medicine Hippocrates in 450 BC, and epinephrine, that is adrenaline, was first referred to its treatment of asthma in 1905. And the usage of oral corticosteroids began to use in bronchial asthma in late 1950s, while the inhaled corticosteroids and the selective short-acting beta-2 agonists such as the salbutamol came into wide use in 1960s. So look at the statistics. The most recent revised global estimate of the asthma suggests as many as 334 million people worldwide have asthma, and the burden of disability is also very high among all populations in the world. And approximately 250,000 people die every year from bronchial asthma, and therefore it is recognized as a public health problem since 1970. So these are the major triggering factors for initiating or increasing the chance of the bronchial asthma, and the major thing are the dust and the pollen grains. So the dust and the pollen grains remains the first two, okay, the most common cause of asthma triggering, and other causes are the smoke, pollution, stress, anger, and the associated with the pets, and exercise-induced bronchospasm, and the bugs, and exposed to the cold air for a longer duration, the strong odors. So this allergens can be divided majorly to easily to remember into 2. That is either by the inspired air, especially the house dust, pollen, feather, and the animal dander, fungal spores, and the second is ingestion. Okay, inspired air and ingestion. So ingestion is mainly by ingestion of the allergens such as the fish, egg, milk, yeast, and the wheat. So these are the major triggering factors. And if you look at the pathogenesis, so the pathogenesis of the origin of the asthma is mainly based on two. So one is the genetic factors, and second is by environmental factors. So this genetic factor by the mutation of HLA gene and the defects in the bronchial airway epithelium, and environmental factors such as hygiene based and the sibling based and antibiotics for a longer duration. So this mainly result in the atopy, that is the the predisposition to an allergic hypersensitivity to the airways, resulting to first exposure to the triggers, as I said, the triggering factors, and this sensitize the helper T cells, lead to stimulation of the beta cells to produce IgE, which mainly binds to the surface of the mast cells, that is the cells which causes release of this mediators. So this activated helper T cells and IgE sensitize the mast cells, causes second exposure to these triggers, lead to especially lead to stimulation, and subsequent exposure to these will result in anaphylactic antigen antibody reaction in the bronchi. Okay. So this causes release of pharmacologically active substances from the cell in the bronchial cell wall, such as the mediators, such as the mast cells, macrophages, and histamines, such as. So this lead to vasodilatation, leading to edema, global cell hyperplasia, leading to increase in the mucus secretion, and bronchial smooth muscle contraction. So all these, so perivascular edema, increase in mucus secretion, and the bronchial muscle contraction, leading to airway obstruction, finally resulting in bronchial asthma. So the maturation of this WBC like eosinophils may also migrate into airways, eyes, and nose. So in eyes, it may result in conjunctivitis, and nose rhinitis, again triggering to asthma. So as I said, these are the cardinal symptoms involved in asthma, such as the frequently coughing, shortness of the breath, feeling tired, excessive fatigability, and wheezing, especially and cold, allergies, and differential diagnosis chest pain. And majority, remember this always, all the symptoms, usually it's high during the night time, especially nocturnal symptoms are high. So asthma exacerbations may be a mild or a severe, and the severe form is the status asthmaticus, and I will discuss you about the treatment of this in my upcoming slides. So all these may lead to respiratory failure if not diagnosed early and treated appropriately with the drugs. So diagnosis, so the spirometry remains the first line of the investigation of choice, and usually in spirometry, the findings will be reduced force expiratory volume, and the reduction in the vital capacity, that is in the force vital capacity, and a reduction in the peak expiratory flow. So all these three, remember, force expiratory volume in 1 second, that is this FEV1, and the vital capacity and the peak expiratory flow. All these three things will be reduced, and this is the cardinal investigation and the finding in the spirometry. And the second are the airway responsiveness. Usually it is done by the methylcholinergics challenge test, and because of spirometry it is not very frequently used nowadays. And third, chest x-ray. Usually it is done because the symptoms are mainly respiratory, and usually there will be findings of hyperinflation and a consolidation. And the skin prick allergic test can also be useful in the diagnosis, especially to identify the type of allergen involved. So clinical classification, as like other diseases, it is mainly divided into mild, moderate, and severe type based on the symptom frequency, nocturnal symptoms, force expiratory volume for 1 second, and the variability of the force expiratory volume, and the usage of short-acting beta agonist. So we go on to the management. So any disease, you should have an ultimate aim at the end of a therapy. So all these aims should be achieved at the end of the therapy. So in the aims of asthma therapy is to decrease or to minimize the chronic symptoms, especially nocturnal symptoms, and to minimize the exacerbations, and to minimize the frequency of the visits, and to minimize the usage of beta 2. Any limitation of activities, including exercise, and the peak expiratory flow circadian rhythm should not be, okay, the variability should not be less than 20%, and the normal peak expiratory flow rate should be achieved, and adverse effects of the medicine should be in a minimal range, which improves the patient compliance. So therapy. So the first line of drug of choice for the asthma remains the bronchodilators such as the beta-2 sympathomimetics. So they are again divided into short acting and long acting. So I will discuss this in my upcoming slides. So the short acting are salbutamol, terbutaline, and the long acting such as the bambaterol, salmeterol, and the methylxanthines such as the theophylline, aminophylline, toxophylline are mainly useful as a drug for the parenteral administration. Such as ipratropium bromide, tiotropium bromide, and the second line, okay, remains the corticosteroids used along with bronchodilator. So systemic corticosteroids such as hydrocortisone, prednisolone, and inhalational corticosteroids such as beclomethasone, budesonide, fluticasone, cyclisonide, and flunisolide. So other drugs, leukotriene antagonists such as montelukast, zafirlukast, mast stabilizers such as sodium chromoglycate ketotifen, and anti-IgE antibodies such as monoclonal antibodies such as omalizumab. So always any question. So here bronchial asthma is usually asked in essay question, and these drugs can also be separately asked in your short notes. So always, if you start with any topic, always start with the classification, especially in pharmacology, start with the classification. So memorize the classification, never mug up the classification. So if you memorize the classification of individual drugs, it will be easy for you to approach the essay as well as to approach the short notes. Okay, so always memorize, okay, and you memorize each and every drug and you write it and see. You cannot just like that memorize. Always after reading the classification, you write and see. So drug therapy is mainly divided into two, the relievers and the controllers. And the relievers are mainly short acting such as beta-2 agonist, anticholinergics, methylxanthines. And the controllers are the corticosteroids, mast stabilizers, leukotriene antagonist, and the biological agents such as the omalizumab. So as I already explained, short acting and long acting. So going on to the first group of drugs are the beta-2 sympathomimetics, such as beta-2 agonists. So they are mainly classified into short-acting and long-acting. And short-acting salbutamol, terbutaline, levosalbutamol, and the pirbuterol. Long-acting salmeterol, formoterol. Long-acting is a newer drug, indacaterol, which was not yet approved by the US FDA for the treatment, and this drug is still under the pipeline. Okay, so if you look at the mechanism of action, the exact mechanism of this beta-2 agonist is to relax the airway smooth muscle and to inhibit the release of the bronchoconstricting chemical mediators from the mast cells, to inhibit the microvascular leakage and to increase the mucociliary transport by increasing the ciliary activity. So this is the ultimate aim of this drug to act. Okay, so this drug, this short acting, the beta-2 agonist mainly acts on the two pathways. Okay, so the inositol phosphate 3 the pathway is reduced and the calcium activated, the potassium channel activation is increased. Okay, so this drugs mainly acts on this pathway. So how this beta-2 agonists are usually short acting as well as long acting. It is the prolonged action is mainly believed to be long because of the lipophilic part in the structure which binds to the nexo receptor in the vicinity to the beta-2 adrenoreceptor on the airway smooth muscle. So this, as a result of this, local availability of the drug function as a slow release and depot that provides a drug to adjacent beta-2 receptors over a longer duration. So remember the three main important drugs such as salbutamol, formoterol, and salmeterol. Okay. So other actions are acute anti-inflammatory effects such as inhibition of the mast cell mediator, inhibition of the plasma exudation, increased mucus secretion and enhanced mucociliary clearance, and reduction in airway cholinergic nerve transmission. And there is no effect on airway hyper-responsiveness. Okay, so short acting are mainly rapid acting which lasts for 3 to 6 hours and usually given as a inhalational route and drug of choice for acute asthma symptoms and exacerbation of asthma. and regularly long-term use of short-acting is not recommended, used on a daily basis, and long-acting is usually recommended. And salbutamol remains the first line of drug of choice for a short-acting beta-2 agonist, and the peak action is usually occurs in in the initiation at the 5 minutes itself and lasts for 2 to 4 hours, and used to abort or terminate the asthmatic act. Related side effects are the muscle tremors, palpitation, nervousness, and the throat irritation can also occur following an inhalational route. And the oral administration is usually not preferred because of the side effect. Long-acting salmeterol formoterol duration is 12 hours, and this do not control the underlying inflammation and increase the mortality in asthmatics. So usually not used as a monotherapy and used in combination with the corticosteroids. So dose is 50 microgram twice daily for the salmeterol, and formoterol is 12 microgram twice daily. Safety issues usually, okay, salmeterol with the placebo, it was found to increase mortality and exacerbation because of increase in markers of inflammation, and maintenance of lung function may also burst if used as a single end. That's why. So this is usually, okay, so the adverse effects is usually monitored by asking the patient for the frequent visits to use along with corticosteroids. The adverse effects, hypokalemia is a major adverse effects because this, okay, beta-2 agonist increases the entry of potassium into the cell. Muscle tremors, palpitation usually in elderly patient, and hyperglycemia usually occurs if taken at large doses and frequent doses, and tolerance occurs sometimes because of downregulation after a chronic therapy. So recent advances, indacaterol is not to be effective in patients with chronic obstructive pulmonary disease, that is COPD. So going on to the second group of drugs such as the anticholinergics. So this anticholinergics examples are the ipratropium bromide, tiotropium bromide, and oxytropium bromide. And however, these remains a less effective bronchodilators when compared to the beta-2 agonists. So they act by causing bronchodilation by binding to the M3 receptors in the airway smooth muscles, and thereby preventing the action of acetylcholine released from the parasympathetic nerves. So this act by reducing the cGMP levels in the bronchial muscle by blocking the M3 receptors. So, and disadvantage, it does not reduce mucociliary clearance, less effective than the beta-2 agonist, and hence it is used only as an add-on therapy in combination with the beta-2 agonist such as the salbutamol. And adverse effects remains a bitter taste, dryness of mouth, glaucoma because of the increase in the because it causes pupillary dilatation, and paradoxical bronchoconstriction can also occur, and urinary retention in elderly patients. So going on to the third group, that is the the methylxanthines. So this is nothing but the phosphodiesterase inhibitor, which mainly causes inhibition of the phosphodiesterase 3, which is mainly present in the airway smooth muscle, and also phosphodiesterase 4 present in the eosinophil and the mast cells. So these two specific isoenzymes are responsible for the metabolism of the cyclic AMP. So the cyclic AMP levels therefore get elevated, leading to bronchodilation, and also act by blockade of adenosine receptors and the airway smooth muscles. Okay, so this also promote an anti-inflammatory action. Clinical available compounds are the theophylline, doxyphylline, and the aminophylline. And the pharmacokinetics is most important since because it's one of the drug of narrow therapeutic index. So therapeutic range is 5 to 15 milligram per liter, and orally the drug rapidly get absorbed and metabolized by liver, and it's one of the important drug for the therapeutic drug monitoring. As I already said, it's the most important drug for the parenteral administration, which is indicated in severe asthma. So oral preparations usually not recommended because IV preparation plays a major role, and followed by inhalational beta-2 agonist and corticosteroids. So it's mainly indicated for a steroid sparing effect, and in the nocturnal asthma as an add-on therapy in patients who are less effective for the beta-2 agonist. And adverse effects, as I already said, it has an narrow therapeutic. So plasma concentration dependent adverse effects like headache, nausea, vomiting, gastric side effects, diuresis, and at higher The adverse effects in the recent advances are mainly due to systemic effect of the phosphodiesterase receptor. So based on this, an oral phosphodiesterase 4 inhibitor such as rofimilast was tested in asthmatic patient. However, gastric side effects was more, and inhalational was also tried for the asthma treatment. So moving on to the third, corticosteroids. So mechanism of action, the most important drug, okay, mainly used as a controller, as I already said. They mainly help in reversing the pathologic, okay, the process of the bronchial asthma. They enhance the beta-2 adrenergic receptor response by upregulating the beta-2 receptors in the lung, and they inhibit the release of the inflammatory mediators such as the prostaglandins and the leukotrienes, and thereby preventing the smooth muscle contraction, vascular permeability, and airway mucus secretion. And they also produce eosinopenia, which prevents cytotachy effect of the mediators released from the eosinophils. They inhibit the formation and release of cytokines and the chemical mediators. Therefore, corticosteroids are usually not used as a prophylactic but effective in preventing the late asthmatic response, thereby decreasing the bronchial hyperresponsiveness. So the major action is the anti-inflammatory action, and they induce the eosinophil apoptosis, prevent the reverse increase in vascular permeability, and decrease the mucus secretion, thereby causing reduction in the airway hyperresponsiveness. Okay. So the synergism, if you see steroids, they increase the transcription of beta-2 receptors, I already said. Beta-2 mainly enhance the binding of the GR receptor. And these are the inhaled corticosteroids used, beclomethasone, budesonide, fluticasone, ciclesonide, which remains the first line of choice in patients with acute asthma. This inhaled corticosteroids mainly causes bronchodilation, and which may result in decrease in the frequency of asthma. So adverse effect, as you already know, any corticosteroids when inhaled result in hoarseness of voice and weakness of voice. So always any patient who use an inhaler should be asked to rinse the mouth after the usage of the inhaler, especially in combination with the corticosteroids, and oropharyngeal candidiasis and cough. So when it is done, the rinsing of mouth is done after every usage, this adverse effects will become less. These are the local adverse effects. And also to reduce this, you can use a large volume spacer, rinse your mouth as already said, switch to DPI if the cough is troublesome. Systemic adverse corticosteroids, you all know it's mainly endocrine related, adrenal suppression, growth suppression, dermal thinning, osteoporosis, cataract, glaucoma, and metabolic abnormalities occur. Minimize this, use the drugs which has high phosphometone such as the budesonide, fluticasone, thereby it reduces systemic bioavailability, and ciclesonide, which is an active metabolite, therefore the less systemic adverse effects occurs, indicated in all three types of asthma, mild, moderate, and severe. And also already said, again it is also used as an add-on therapy with short-acting beta-2 agonist. Okay. Systemic steroids usually given in moderate to severe type of asthma. So the prednisolone 30 to 40 milligram per day, and at a maintenance dose of 10 to 15 milligram per day is used. And usually the dose is tapered and stopped in patients who the symptoms reduces, and usually given at the morning dose to match the diurnal variation of the cortisol. So intravenous steroids, as it implies, it is used mainly in acute asthma. Going on to the new group, mast cell stabilizers. So it mainly inhibits the degranulation of the mast cells from the triggers such as exercise and the pollen, and inhibit the eosinophilic recruitment, and it is well tolerated in the treatment of childhood asthma. So anti-leukotrienes, so as the name itself already says, so it is a leukotriene receptor antagonist. So leukotriene is a powerful mediator of inflammation and stimulate the bronchoconstriction. So metabolism of this arachidonic acid via the lipoxygenase pathway activates the cystinoid leukotriene receptor to cause bronchoconstriction. So this drug mainly acts by inhibiting this, okay, the leukotriene receptor, inflammatory receptor. So indicated mainly in what is it? In case of an add-on therapy in patients with the intermittent asthma and in the mild asthma, and also in aspirin-induced asthma. So montelukast remains a first line of choice. Okay, 10 milligram per day. So adverse effects, it's very less and very rarely liver dysfunction, Church-Strauss syndrome, and headache and rashes. And the newer drug, malizumab, which is an anti-IgE antibody. It's an entirely new approach towards the treatment of asthma, involve the development of humanized monoclonal antibody, the free IgE without the mast cell, gives the exacerbations. Major disadvantage, it is very expensive and administered as a subcutaneous injection at 2 to 4 weeks, and anaphylactic reaction remains the major disadvantage. Status asthmaticus. So an acute asthmatic attack which is not responding to the rotate beta 2 agonist, and this is a life-threatening condition usually precipitated by acute respiratory infection, abrupt cessation of steroid therapy, and acute emotional stress, pharmacological stimuli, allergens. So this is a treatment protocol for the status asthmaticus. Any patient who has to be admitted first, the patient has to admitted, check the airway breathing circulation. So this is a general management followed by the specific management. Hydrocortisone emisoxenate, 100 milligram IV stat, 4 to 8 hourly infusion. Nebulized salbutamol, 2.5 required salbutamol terbutaline can be given in subcutaneous or intramuscular unless required. Usually it get controlled by oral route itself. If required, can be given, and mechanical ventilation intubation for the patient where saturation level does not maintain. An antibiotic in patients with severe acute respiratory infections can be initiated, and saline, the soda bicarb can be initiated mainly to bring down the acidosis. So as an additional clinical information, I have added the types of inhalers. The first is a meter dose inhaler, which is where a metered amount of the dose goes directly into the lung, which can be adjusted. In adjusted type, the dose can be okay. So the patient can be on the breath acute MDI used for the patient who are unable to coordinate inhalation, and the very common patient errors is you have to shake the canister before the use. That is a major thing, and inhaling at the wrong time. And after pressing the canister, the patient has to hold the breath so that the drug stays in the airway and the absorption occurs. Okay, so first meter dose inhaler. Second is a spacer holding chamber where this meter dose inhaler is connected to a spacer, and this acts as a reservoir for holding chamber for the drug, and it is fitted with a one-way valve to prevent the medication escape. This is a spacer, and at the patient end, the mouthpiece can be attached. Especially this is found to be helpful in children. An advantage is decrease oropharyngeal deposition and decrease risk of topical side effect, and no need for coordination with the breathing. Third is the dry powder inhaler, also called as DPI. They deliver drug in the form of dry powder gas. They rely on patient's inhalation to trigger the delivery. And these are the types: alcohaler, turbohaler, and the dishaler. These are types. A nebulizer, you all know, patient with the severity can be used. And a few patients also have nebulizer in their home. They turn the liquid forms the drugs into a fine mist like an aerosol, especially aerosol, the drug delivered during the tidal breathing. So this is a method of choice in patients with breathing fatigue and in severe asthma, where large dose of inhaled drugs need to be administered. Approach for the bronchial asthma first is to develop a doctor-patient relationship, because the patient has to come the doctor for a frequent review to assess the severity. The patient may come at the severity, and it may come down to moderate and the mild, and the ultimate aim of the drug therapy should be achieved. Second is identify and reduce the exposure to the risk factors. Especially many patients will be having a pits in their home. They will be exposed to frequent pollen allergies. So identify the risk factors, assess, treat, and monitor the asthma. And the fourth important thing is to manage the exacerbations. Okay. This is the stepwise management of the asthma. So as a importance of the clinical part, as I said, so the first line always remains the short-acting beta-2 agonist in combination with an anticholinergic such as ipratropium, or with the inhalational corticosteroids, especially low-dose inhalational corticosteroids. And this is the stepwise management as a treatment protocol. So as a special condition, pregnancy and asthma, it's a very frequently asked question, whether you have to continue the drug in pregnancy or to stop. So you all know asthma increases the risk of preterm intrauterine growth restriction. So therefore, you should never withhold the treatment, because increase in chance of the perinatal mortality is more if you stop the treatment. Okay. So You have to monitor the asthma status during the prenatal visits, and salbutamol remains the first line of drug of choice. Okay, because it has an excellent safety profile, and inhalational corticosteroids are the preferred for a long-term control, and such as the Medusane remains the first line of drug of choice. So all the best, read well. Thank you.